The following podcast is part of a certified educational activity titled Show Me the Data, Improving Renal Outcomes with Glucose-Lowering Therapy in the Individualized Management of T2DM. Access the entire activity and complete the post-test at peerview.com/RBT860. Downloadable infographics and additional resources are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
I'm Dr. George Bacris, Professor of Medicine and Director of the American Heart Association Comprehensive Hypertension Center at the University of Chicago Medicine. Welcome to this CME activity entitled Show Me the Data, Improving Renal Outcomes with Glucose-Lowering Therapy in the Individualized Management of Type 2 Diabetes. We're going to look at various aspects of Type 2 diabetes and CKD. What you can see is the worldwide distribution and projections of diabetes in the world going out to 2045. And you can see the parts of the world that already have a lot of diabetes and where the greatest increases in diabetes are going to be. And I think this is important to have in mind that this is not a problem that's just for today or tomorrow. This is going to be going out for many, many decades. Now, why is this important? Well, it's important because by far in the world, the most common cause of diabetes is obesity, but we also have to know that diabetes is the most common cause of kidney failure. The two most common causes of kidney failure in the world are diabetes, by far number one, and then number two, hypertension, a distant second, which previously was number one. Now, as many of you know, there is an interaction between diabetes, risk of cardiovascular disease, and risk of kidney disease. And in fact, if you actually look at some statistics, 35 to 45% of patients with heart failure have CKD. 20 to 44% of people with type 2 diabetes have CKD. 60% of patients with heart failure and type 2 diabetes have CKD. And in fact, if you look at the pathophysiology of diabetic kidney disease, you can see that there's not one dimension. It's not just the glucose contributing to these problems, but there are a number of changes that occur, hemodynamic changes, cellular changes, and changes that lend themselves to fibrosis and worsening of kidney function ultimately, and that's where your risk comes in. We're now going to go to the next section, which is focusing on improving renal outcomes in patients with type 2 diabetes. You can see that there have been a number of changes that have occurred in 2001, largely led by these two trials, the Renal and ID&T. And that really changed the landscape and slowed progression of kidney disease. But you can see there's a huge residual risk. And so there was a lot of work to be done. And there were many, many studies that were done between 2001 and the current day. All, unfortunately, failed to show a benefit in terms of slowing progression of kidney disease. And then we had a number of studies that were done with glucose-lowering agents, and these were done for safety reasons mandated by the FDA. However, some of the more recent agents, the GLP-1 receptor agonists and the SGLT2s, showed us very promising data that we never had with any of the previous compounds. In fact, none of the previous compounds actually showed any benefit on the kidney or the heart. The GLP-1 receptor agonists showed very positive data on cardiovascular outcomes. The kidney data is pending, so we don't know. But the SGLT2s were very positive both in terms of kidney and cardiovascular disease. And in fact, if you look at this meta-analysis by Zelniker, you can see across the board that whatever cardiovascular outcome you want to look at, what's the composite of MACE or even heart failure, and even renal endpoints. They are all positive in the SGLT2 trials. Now let's talk about a seminal study which really has led the charge in renal outcomes, and that is the CREDENCE trial. Now, full disclosure, we were writing the CREDENCE trial starting in 2011, way before a lot of these studies were ever published. So we suspected that there would be some positive outcome, not to the magnitude that it ultimately happened, but some positive outcome on that. Now you can see this heat map, and I want to make this point, doesn't just look at GFR, but it also looks at albuminuria. And so to really get a complete picture of what stage of kidney function you're in, you have to measure the urine albumin, period. And that's not being done. You can see the colors reflect the risk, not just renal risk, but also cardiovascular risk. And very important to note that the trials that everyone quotes for cardiovascular benefit really had totally normal kidney function. There was a subgroup with some renal insufficiency, but in general, they were pretty healthy people in terms of renal function. And CREDENCE, you can see, was quite the opposite. CREDENCE represented here by the star, much lower GFR, much higher albuminuria. And when you look at renal replacement therapy, i.e. dialysis, you can see here that amongst all three trials, combined close to 30,000 patients, only 29 people required dialysis. CREDENCE, with 4,400 people, had 176 events requiring dialysis. So, very important observation to note. Now, CREDENCE, you can see here what the study design is. These are people with diabetes. These are people that had at least GFRs or urine albumins that would put you in that red box. And if you were on dialysis or you had a transplant or you had a recent CV event, you were excluded, or if you had heart failure. And this was randomization to canagliflozin 100 milligrams or placebo. And it was double-blind. Follow-up was 2.6 years. It was event-driven, and keep in mind this trial was stopped early for overwhelming benefit. So very important to note. And the primary outcome was a composite renal endpoint, ESKD, doubling of creatinine, renal death, or CV death. So, again, clearly geared for renal outcomes. And you can see here the primary outcome showing a 34% risk reduction for renal-specific composite endpoints. So there's no question there's a benefit here, and the FDA certainly appropriately gave labeling. Now, I think what's also important is you do not have to have diabetes. This is not a glucose-lowering benefit. This is a benefit independent of that, and I'm going to get to that in a second. I also want you to understand this is not your mother's diuretic. If you look at this initial drop in GFR, many people thought this was like an ARB, ACE inhibitor effect. Not true. This is not a substitution for an ACE or an ARB. You can see that that initial drop is a function of how good your kidney function is. The lower your GFR, the less the drop. And there are data coming out that in people with GFRs below 30, that drop isn't there at all. So I think it's important to understand that is a physiologic phenomena. It's a function of how good your kidney function is and how high your glucose is. So just keep that in mind. Now, having said that, we had a 32% reduction in albuminuria that was sustained. And the other very important point is, just like the ACE inhibitors and the ARBs, you had an initial reduction in GFR, and then it plateaued, it stabilized. It did not fall as much as the placebo group. And that is very important because that translated into slowing disease progression from that 4.4 mLs per minute per year down to about 2 mLs per minute per year. So, very important benefit seen with the SGLT2s. Now, I think we need to take this one step further. How many people do you have to treat to get a benefit? This is something that is really powerful. 22 people are all you need to treat to reach the primary composite endpoint. What about renal replacement therapy? 16 people, even fewer. So it is very important. If you're worried about the cardiovascular events, okay, heart failure, 46 people. So very important to keep this in mind. Many people are concerned about safety with SGLT2s. Well, if you take a look at what your GFR was, low or high, there definitely were no safety concerns for heart failure, adverse events, fractures, or amputations. And you'll see in a second that The FDA has acknowledged this as well. And in fact, if you look at the original warning label, the major things that you needed to worry about were ketoacidosis, urinary tract infections and urosepsis, and genital mycotic infections. The ketoacidosis, I just want to clarify for you, is a problem primarily and almost exclusively in people on insulin or sulfonylureas. And it was seen if they had a GI disturbance. So what you need to do is tell the patients that if they are having these kinds of problems and they're stopping their insulin, they need to stop their SGLT2. Number two, genital mycotic infections. Basically, my experience with this is if you keep the area dry, you will really not have major problems with it. If you don't, you will. So that's just some general thoughts. Now, I want to share with you something that literally was just published, and it's a major change in FDA label, which frankly does not occur often. But I think it's important as clinicians that you know this. Number one, adults with type 2 diabetes and an eGFR as low as 30 with or without albuminuria may start, and of course this is the canagliflozin label, 100 milligrams of canagliflozin. However, continuation of canagliflozin is not recommended in people whose GFR falls below 30 unless they have greater than 300 milligrams of albumin. Again, another reason to measure albumin. The box warning for lower extremity amputations was abolished, and they said we no longer believe this risk meets the standard of a box warning. So again, very important. Also removed acute kidney injury as a standalone warning. And they said that that warning, an additional warning that was there, symptomatic hypotension can occur with ACEs or ARBs. They removed that. So again, major changes in labels. Now, if we look at renal outcomes in the other trials, and I told you they did not have the same low GFR, but if you take the totality of all the studies across the board, people do better in the SGLT2. There's no question about it. Now, more recently, there is the VERTIS trial. And the VERTIS trial looked at ertigliflozin, the latest newcomer of the SGLT2s. And what we have here are data on eGFR, and they come from two different studies. One was ertigliflozin with metformin background therapy, and the other was ertigliflozin with glimepiride background therapy. And they looked at eGFR at 6 weeks. It was reduced, and it's consistent with everything that you would expect with the SGLT2s. They followed people out for over 104 weeks. And what you can notice here is there definitely is a reduction in micro and in macro over the large part of the study. Not as clear cut as you've seen in some other studies, but the trends are definitely there. When you look at the totality of data from all of the trials, it probably is a class effect, and many people think that that's probably true. So I think I would put that out there for you as well. Bottom line is, this whole tubular-glomerular feedback issue, you should know it takes about 25 seconds for tubular-glomerular feedback to occur. So this is not some long-standing phenomenon. It also does not occur in people with GFRs that are well below 40. There's good animal data on this. There's no human data. But you can see here it is highly relevant in people. In fact, it's the majority of people that have GFRs above 45. So important to note. You can see that there are multiple mechanisms. And SGLT2s, we really don't know how they work. They're not your mother's benign natriuretic factor agent. They definitely affect inflammation directly through inflammasome activity. They definitely affect oxidative stress. And so definitely they are multi-purpose. And in fact, I'm on record in the American Journal of Kidney Diseases where they asked me to write an editorial, and I basically said these are cardiorenal risk-reducing agents that have glucose lowering as a beneficial side effect. And there are data now in outcome trials that are supporting that statement. You need to know that this concept has been embraced by the American Diabetes Association. I think it's important for you to know that these guidelines are far more than glucose control, and we've gone way past that. I also want you to know that these are endorsed by the ACC, which means the ACC looks at these and wants to make sure they are congruent with their guidelines for patients with diabetes. So they're already endorsed by ACC, and I can tell you coming up, the International Guideline Committee for Kidney Disease and Diabetes, the KDIGO, is also for 21 going to try to have endorsement there as well. Lifestyle is still key no matter what. However, metformin has not been knocked off as initial therapy, but as many people would point out to you, doesn't have a great portfolio for cardiovascular risk reduction. So what we've done over on the left part of this is we say consider independently of baseline A1C. So we're outside of glucose now. If you have heart failure and or CKD, if these are clearly in the patient's picture, if you're on metformin, that's fine. They need to be on an SGLT2 inhibitor because of the overwhelming data of positivity. You do not need to worry about hypoglycemia. It does not exist with this class of agent. And if they've got reduced kidney function, you definitely don't have to worry about glucose. And as we said, these drugs do not work by lowering glucose as their mode of action for benefit. They have other mechanisms. So I think it's important to understand that the diabetologists, along with the cardiologists, and I dare say the nephrologists, because I've seen the upcoming KDIGO, definitely appreciate the benefit of this class of drugs independent of glycemic control. And so I think they need to be looked at in that way. Here you can see some renal-specific trials with SGLT2s. Some of these are completed and some of these are ongoing. CREDENCE, of course, is completed. DAPA-CKD is also completed, also stopped early, and the uniqueness of this trial is that at least a third of the patients did not have diabetes, and yet they were very similar to the CREDENCE population. EMPA-KIDNEY is not going to be ready till 2023, but it's also looking at a mixed group of people. You can see here that they've excluded polycystic disease, lupus, ANCA vasculitis, and type 1 diabetes. It was event-driven, and the primary outcome was greater than 50% decline in eGFR, ESKD, renal, or CV death. So very much like CREDENCE. The inclusion criteria, as I said, there were at least a third or more without diabetes, and the GFR went down to 25. Keep in mind, it was event-driven. Keep in mind that the trial was stopped early for benefit, and it was just slightly smaller than CREDENCE of 4,300 people, and the primary outcome was a 50% decline in eGFR, ESKD, renal, or CV death. So, very much like CREDENCE.
DAPA-CKD was the first study to show positive data for an SGLT2 inhibitor in a broad CKD population with and without type 2 diabetes. Primary and secondary composite outcomes showed a sustained greater than or equal to 50% reduction on eGFR, end-stage kidney disease, and or cardiovascular renal death in patients receiving dapagliflozin. The study also showed prolonged survival and reduced risk of worsening kidney function or death from cardiovascular or kidney disease with dapagliflozin among patients with chronic kidney disease with or without type 2 diabetes. Dapagliflozin was well tolerated in keeping with its established safety profile.
And then EMPA-KIDNEY is a little bit bigger trial. And again, you can see here, multi-center, 7 countries, 6,000 patients, very, very large trial. Again, inclusion criteria very similar to what you saw in DAPA-CKD. Again, excluding polycystic disease, diabetes, type 2 diabetes, and atherosclerotic disease in people with GFRs greater than 60. And of course, interestingly, bariatric surgery. Here, the primary endpoint is a renal endpoint, which is sustained decrease in GFR less than 10 mLs per minute, sustained decline of greater than or equal to 40% in GFR, ESKD or renal death, or CV death. So, what are the take-home messages? The take-home messages are diabetic kidney disease is becoming much more prevalent in the world. Newer approaches have demonstrated slowing of CKD progression. SGLT2 inhibitors should be thought of as a cardiorenal risk-reducing agent with glucose lowering as a beneficial side effect. And finally, CREDENCE was the first trial powered for renal endpoints, but additional trials of SGLT2s continue to show benefit in renal endpoints in patients with type 2 diabetes. Thank you for listening and have a good day.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RBT860. This activity is supported by independent educational grants from AstraZeneca LP, Boehringer Ingelheim Pharmaceuticals Incorporated, and Lilly USA LLC, and Merck & Company Incorporated. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.